Welcome to this presentation on postpartum mental health. Mental health conditions are the most common pregnancy related complication in the U.S. Yet, stigma and insufficient screening leave many feeling isolated in their struggles. This presentation aims to raise awareness about perinatal mood and anxiety conditions, empowering you to recognize symptoms early and seek support for your mental well being. On this slide, I've listed some of the most common postpartum mood and anxiety disorders and their prevalence in the general population. Keep in mind that these numbers may actually be higher due to underreporting and lack of screening. In this presentation, I'll focus on the two most common conditions: postpartum depression and postpartum anxiety. For more detailed information on the other conditions mentioned, I've included links to reliable resources in the Learn More section. It's important to note that these conditions vary widely in severity. Some mothers may experience only a few symptoms, while others may experience all. Regardless, all deserve care and treatment. Don't compare yourself to the experience of other mothers you know or to statistics. And don't wait for symptoms to worsen before seeking help. Your well being is unique to you. You are the expert, and therefore you have the right to seek support whenever you decide you need it. Let's kick things off with a look at how to tell if what you're experiencing is the baby blues or something more. The most common symptoms of the baby blues are crying or feeling emotional for no reason, irritability or touchiness, low mood, anxiety and restlessness, mood swings, difficulty sleeping, and poor concentration. 80% of parents experience baby blues starting within the first 2 to 3 days after birth and resolving gradually without intervention within the first 2 to 3 weeks. It is largely driven by the massive drop in the hormone progesterone that follows the birth of the baby, but it is also attributed to the major life adjustments that come with bringing a new baby into the mix. The baby blues is going to be different than the other conditions I cover in this presentation in two key ways. Number one, it self resolves when hormones rebalance after the birth. And number two, it is time limited. It ends within the first 2 to 3 weeks postpartum. If you're experiencing symptoms of baby blues past the 2 to 3 week mark, then it is possible you're experiencing postpartum depression, and you should discuss your options with your care provider. Even before the 2 to 3 week mark, if your symptoms are severe, frequent, and or interfering with your ability to care for yourself or your baby, then don't wait for them to resolve on their own and reach out for help. Okay, so what does it look like when the baby blues crosses over into postpartum depression? You can see from this image that the patterns consistent throughout are that the symptoms increase in severity, frequency, and impact on daily life. This is considered postpartum depression. Those experiencing postpartum depression will be experiencing these symptoms daily. This is different than just having an off day where you feel more sad or irritable than normal. Postpartum depression impacts your ability to function normally or to enjoy things that used to make you happy. I want to quickly note that some people don't recognize that they are depressed because we have this idea that depression means you lie in bed all day, feeling stuck and having no energy. But again, remember there is a range and symptoms can present differently in different people. Often it can also manifest as a general feeling of indifference, especially towards things that used to bring you joy. Now your emotional range is flat, where you may have once found a strong emotional reaction to something. Your response is now more meh or just blah. This can also be a sign of depression. So just keep that in mind as well. Now let's look at the second most common mental health condition in the postpartum period: postpartum anxiety. We know some degree of worrying after childbirth is extremely common, if not universal. Worrying is how we experience our brain's attempts at trying to make sense of this major transition and new responsibility. However, postpartum anxiety is more than just feeling worried. With postpartum anxiety, the worry is overwhelming and frequently interferes with daily life. It can be vague or generalized or related to specific events from your past. Some ways it may show up include not getting any rest due to frequently checking on the baby while he or she sleeps for fear of SIDS, or not being able to leave the house with the baby for fear of a car wreck. Screening for postpartum anxiety is often lacking, and its symptoms can overlap with those of postpartum depression. It's common for people with postpartum depression to experience signs of postpartum anxiety, but not everyone with postpartum anxiety is also depressed. So, even if your nurse or provider doesn't mention your screening results, talk to them about what you're experiencing. Postpartum depression and anxiety are the two most common conditions, but now I want to move on to some common experiences in the postpartum period that can be part of the cluster of symptoms associated with a perinatal mood and anxiety disorder, but can also be experienced by those who do not have a perinatal mood and anxiety disorder, and therefore can catch people off guard and cause distress and confusion, especially if you haven't heard of them before. One of the less talked about aspects of parenthood is the occurrence of intrusive thoughts. Simply put, intrusive thoughts are the sudden concerns, worst case scenarios, or irrational fears that arise in your mind, often concerning potential harm to your children. For more in depth information, I've included a great article in the Learn More section. Intrusive thoughts are very common, but they can be disturbing as they conflict with our expectations of parenthood being a time of pure bliss, bonding, and fulfillment. To help develop self compassion during these unsettling moments, it can be helpful to know that the root cause of these intrusive thoughts is simply our brains trying to make sense of the added pressure of caring for a vulnerable infant, and that means that our fight or flight system is on high alert for possible threats. So, even though when the thoughts occur, your internal dialogue might be, "Whoa, where did that come from? That was weird, scary, or gruesome. What's wrong with me?" And you might feel shame or guilt. Note that this is part of our natural wiring that puts us on high alert and is meant to predict and prevent harms to ourselves and our infants. So be compassionate with yourself and know that good mothers do think bad thoughts and that thoughts do not define you. Now, if the intrusive thoughts become severe, frequent, or begin to impact your ability to care for yourself or your child, they could be a sign of postpartum anxiety or OCD. If you can no longer distinguish the thoughts from reality, or they no longer worry you because they feel in alignment with your desires, this is a sign of postpartum psychosis, which is extremely rare but requires immediate professional intervention. The next topic is postpartum rage. Postpartum rage often stems from feelings of overwhelm, resentment, unmet expectations, feeling a lack of control, and or guilt. It currently does not fit neatly within the diagnostic criteria boxes of the accepted perinatal mood and anxiety disorders, but that doesn't make it any less valid and deserving of care. This is also true for birth trauma, which may or may not progress to birth related PTSD. Birth trauma can occur from a birth experience that didn't go to plan in any number of ways. It is important to process this experience in a safe and supportive environment. Lastly, there is a hormone mediated experience known as dysphoric milk rejection reflex, which causes some women to experience brief but intense feelings of sadness just prior to milk letdown. Research is still developing regarding dysphoric milk ejection reflex, and it is rare, but I want to mention it here because without awareness, it can be difficult for mothers to identify the pattern of sadness linked to letdown. I'll provide more information on the available research in the Learn More section. To summarize this slide, note that screenings aren't always reliable, as some feelings and experiences will fall outside of the perinatal mood and anxiety disorder criteria, but they do have the potential to lead to the development of a perinatal mood and anxiety disorder if not addressed. So don't wait to be diagnosed with a perinatal mood and anxiety disorder. If you're having feelings that are severe, frequent, and impacting your daily life, you still deserve to receive care. 10 to 14% of dads will experience postpartum depression. The typical onset is between 3 to 6 months. Postpartum depression can also affect same sex couples, partners, and adoptive parents. All parents need more support as they navigate the demands of caring for a new infant. A birth brings many challenges to family life, such as changing roles, a steep learning curve, demands on finances, relationship challenges, sleep disturbances, identity loss and shifts, having to put certain personal passions on hold, and nervous system overstimulation, to name a few. The challenges faced during this transitional time increase the risk of mental health struggles for all caregivers. But there is support available for non birthing parents as well. Okay, so up until this point, we have covered postpartum mood and anxiety disorders. But I want to take a quick moment to cover some of the neurological and physiological changes that occur universally in motherhood and aren't a symptom of a perinatal mood and anxiety disorder, but are changes nevertheless. And change can be difficult to navigate, especially if we don't take time to reflect on what has taken place. Has anyone heard of the term matrices before? I sure hadn't until I started doing a deep dive into motherhood. And once I came across it, I found the idea really eye opening and enlightening. Essentially, you can think of matrescence as being similar to adolescence in terms of the impact it has on our brains and bodies. Sociologists liken it to a complete metamorphosis. Motherhood changes us physically, mentally, physiologically, and in our identity. And that isn't necessarily a bad thing, though it is a huge adjustment. And in order to make sense of the changes in our lives, or to experience the metamorphosis, if you will, it often requires that we allow ourselves to process the parts of our previous lives that we are leaving behind. Even when the baby was planned, even when we love our babies, it is still healthy, normal, and recommended to allow ourselves to take time to reflect on the way things have changed in ways that were not expected with curiosity and compassion. So far, I hope that the key takeaways are that there are many changes that are normal and others that indicate the need for treatment. And that if you find yourself suffering from a maternal mental health condition, you are not alone, you are not to blame, and there is help available. So let's wrap up with a discussion on accessing the help and support you deserve. First off, we have to address the elephant in the room, which is the persistent stigma associated with mental health conditions that is often even more intensely felt by moms due to the idealization of motherhood myth, whereby motherhood is portrayed as all joy, rewards, and fulfillment all the time, when that the reality is that motherhood is full of contradictions. Two things can be true at the same time. Motherhood can be rewarding and absolutely draining. Motherhood can be joyful, and you can also need to take a break. I could go on, but I think you get the idea. The combination of stigma and the motherhood myth creates a cycle where no one speaks out for fear of being alone in their experience, which creates more suffering but less awareness of the suffering, and therefore more sense of aloneness. This is why you often hear people say how once they do open up about their experience, they are shocked to learn that many people close to them have been through the same thing but hadn't shared their story because they thought they were the only one. So it's imperative to find ways to break the stigma and overcome the motherhood myth so that we can experience motherhood in its entirety, with all the contradictions, uncertainty, ambiguity, and nuance that comes with it while supporting one another and getting the help we need. One method I'd like to propose to overcome the stigma associated with mental health conditions is to think of them as no different than physical health conditions. Diabetes is a disorder of our hormone system and its ability to regulate our blood sugar. We would never tell someone with diabetes to tough it out or that their diabetes was a failing of their character or morals. Mental health conditions are no different. They have a physiological imbalance at their core and they require treatment to manage, just like physical ailments. The next step is to find a trusted person to talk to, as again, once we open up, we often find that others have either been in a similar position themselves or know someone who has, and they become an excellent support and an ally for finding verified resources. People truly want to help. Thirdly, practice self compassion. You are not to blame and you are not a failure. Your mental state is just that, a state which you are passing through, and with support, you will get better. The next step in overcoming stigma and the motherhood myth is to acknowledge that needing help is not weakness. It takes vulnerability, but speaking out about what you're going through is taking a powerful and courageous stand. You are saying, I know what I am experiencing is real, is raw, and it is my truth, and I am not ashamed. I can't control how others will respond, but I have the courage to move forward regardless because I am important and my needs are valid. Motherhood is hard work with little sleep, s- sometimes lack of appreciation, stress, steep learning curves, overwhelming responsibilities, expectations that conflict with reality, and not to mention the lack of societal supports. Even the strongest people need support under these circumstances. Support and our relationships are imperative to well being. One step you can take to care for your mental well being is to identify someone who will be your real check in buddy. This person should be skilled in the art of listening without trying to fix. A real check in is more than how are you doing or how are you feeling. It is what was the highest part of your day? What was the lowest? What fears do you have going through your head right now? What are you excited for? What can I do to be more supportive? The next step is to really prioritize sleep to the best of your ability. There's a reason why sleep deprivation is used as a form of torture, and there is a clear association between lack of sleep and mental health conditions. Getting sleep isn't selfish, it's essential. I also want to highlight the incredible resources offered through Postpartum Support International. They have peer mentors who have personal experience with overcoming postpartum mood and anxiety conditions who are thoughtfully matched with individuals in need to provide personalized one on one support. Establishing a one to one connection with someone who has journeyed through a perinatal mood and anxiety disorder offers invaluable insight, encouragement, and hope. They also offer weekly support groups, which are split into over 50 categories, such as LGBTQ families, military families, families with multiples, support for dads, and many more. The CDC estimates that 60% of women with the perinatal mood and anxiety symptoms never receive a formal diagnosis. Too often, that means that women are not getting the treatment that they need. Screening can be an effective tool in identifying and supporting those who need help, but unfortunately, our screening processes are also flawed, resulting in too many who slip through the gaps. So, even if the screenings are no longer being given to you, or if they are, and no one mentions your results, but you feel something is off, talk to your OBGYN, midwife, primary care provider, or pediatrician about what you're experiencing and see what your options are. The bad news about therapy is that it is often inadequately covered by insurance. But I want to point out that many providers offer sliding scale services so that you can find an option that fits your budget. Also, being that insurance doesn't cover therapy, a diagnosis isn't required to get started. You can start at any time, and many providers also offer a free consultation call so you can find the right fit. For many women, talk therapy alone will be adequate for treating their condition. However, for others, medication might be recommended, and this may deter some others from seeking treatment, especially if they are breastfeeding. I want to point out that medications can be safe while breastfeeding, and it is worth it to discuss the risks versus benefits with your provider. On this note, I'd like to provide one more example of how likening mental illness to physical illness can help people overcome barriers to care. As many of you know, it is recommended to not use NSAIDs such as aspirin, ibuprofen, or Advil during pregnancy. However, I took aspirin daily throughout my second pregnancy. Why? Because with my first, I experienced preeclampsia, and aspirin has been shown to decrease the risk of preeclampsia in pregnant women by approximately 20% when taken daily starting in the first trimester. The benefit, even though it's not guaranteed, outweighed any potential risk. I didn't feel shame over this decision, and no one questioned whether I was doing the right thing. This is how it should be when a mother decides to take care of her mental health as well. Furthermore, when it comes to the risk to the fetus or the infant, the data is often incomplete or based off of animal studies, which have been shown to have poor correlation to human subjects. So, when you use Google to assess your options, you are likely to get conflicting facts. As you can see, it's a complicated topic, and discussing your unique situation with your provider is really the best way to get the answers you need. Just because something feels really hard doesn't mean you're doing it wrong. Motherhood is hard. Don't mistake your illness as an indication of your character. Just because you're not feeling well doesn't mean you're not meant to be a mother or that subconsciously you do not want your baby. Mood disorders are cunning. They hijack your internal narrative and make it hard to know what's fact and what's fiction. And an intervention is required to set the narrative straight and help you to see that even the best moms experience challenges. And you are the best mom for your baby. Okay, that's it for me. I hope this presentation has taught you something new, given you the tools to advocate for yourself, and provided encouragement to those who may be suffering. You will overcome this.